For the 40th anniversary of the AAMDS International Foundation, I was really looking forward to hearing a broad overview with some new updates for the various fields of medicine that AAMDS supports. I was in charge of the Aplastic Anemia panel, and I was really privileged to be joined by several colleagues, Dr. Joachim Deeg from the Fred Hutch in Seattle, Dr. Bhavisha Patel from the NIH just down the road here, and then my good friend Dr. Austin Kay from the UK, who specializes all of them in aplastic anemia. I'd hoped that people would really get a broad overview for first the diagnostics by Austin, then the history of match transplant by Joachim, and then Bhavisha talked about 40 years of immunosuppressive therapy, and I rounded us out with alternative donor transplant, which is a more novel approach to the disease in 2023. It's so fun to think about what the most innovative advances in aplastic anemia have been over the past 40 years, because I think really as much as any of the three diseases discussed here, we have made incredible leaps and bounds for our patients. So we really understand the pathophysiology of the disease and how it's a T-cell attack at the level of the earliest stem cell that makes our blood. And we've learned how to use newer techniques like next-generation sequencing to understand the mutations, and that was reviewed very nicely by Austin. Then transplant has always been a way to recover the hematopoiesis for these patients, and it used to be that we could only use a matched sibling, and Joachim reviewed how we use transplant, how we've changed the conditioning, and what still we use today, and then what lessons we've learned that have helped us improve things further over the past 40 years. Bhavisha really showed us how first we had ATG as our only immunosuppressant, then we added cyclosporin, which ironically was approved in 1983, the same year that AAMDSIF came into being. And then more recently, the third addition to the immunosuppressive regimen, which is eltrombopag, and she went all through that data very nicely. And I think the last innovation is the ability to use haploidentical donors for transplant, both in the relapsed and refractory setting and also for the upfront setting. And this has really come to be because of post-transplant cyclophosphamide in many arenas, because it really doesn't have any graft versus host disease effects from it. Really, those are all the therapies. We use bone marrow transplantation and immunosuppressive therapy, and now we know how to use them better with a few additional agents and with really best available donor for those patients. I think from a research perspective, the most promising avenues in aplastic anemia are better understanding of the biology, determining if there are additional perhaps inherited mutations that predispose to this autoimmune hematopoietic syndrome. That will be very interesting. And then I think from a therapeutic perspective, we're going to see additional progress in both the transplant and immunosuppressive regimens, but we're also going to learn how to really individualize this for a patient and their goals. Transplant may not be for everybody. We need to learn how this affects fertility or quality of life. Immunosuppressive therapy may not be for everybody because some people really need a total reset of the immune system by something like transplant. And these will be very fun things to study and help our patients with in the next 40 years. Certainly for aplastic anemia patients and their families, this is a complete shock to the system when the diagnosis gets made. And I would encourage them to find, in an efficient fashion, a provider that they trust, maybe get one or two opinions. I think a transplant opinion probably should be one of those. And then really have open conversations about what the disease means, make sure the disease is diagnosed correctly and well characterized, and then quite efficiently pick a treatment that really has the goal of reconstituting the hematopoiesis for them as a patient with the support system of their family.